Let me introduce the session and then join you. So this is a virtual theater number 2, the ASAN Live Case 1 and 2. My name is Alan Yeung, and together with me is Dr. Myeong-Ki as moderators. And our panelists include Dr. Akasaka, Dr. Chen, Dr. Lee, Dr. Murasato, and Dr. Tahk. Good morning, Dr. Park, and let's start with the case.
First of all, I'd like to really, thank you all for the joining our, it's real live, however, virtual complex PCI course. Really, we have a lot of, effort to overcome the corona, COVID-19. However, I really wanted to looking forward to see you all in the, face to face. Dear. All right, we're gonna start second cases. Actually, we have a rising stars. Young Dr. Kang Do-Yoon here, a fellow Dr. Jung-hoon here is my a fellow. The fellow is Dr. Zhang. Mr. Zhang is here. All right. You introduce?
Yes, I will introduce the case.
Right, case first.
Yes. The patient is a 57-year-old female referred from Ipoh angina. And he took angiography from other hospital and recommended PCI because of the sleep vessel disease and visited our hospital. Next, he has previous history of hypertension and hyperlipidemia. Next, and he took her angiography and the syntax score was 34 point. And next, we reviewed the angiography and checked the angiography again in our hospital. There is some intermediate disease of the Prox RCA and the FFR was 0.85. It was functionally insignificant. Next. And this is the target region, the left main, and Prox LAD diffuse region.
Okay, why don't you show the real
yes.
Pictures today?
Picture, yeah.
All right, and so from the first picture. All right. Alan, can you see that?
Yes, I can.
All right, great. Actually, patient had a very unstable status, and so after the first angiograms, another hospital, the doctors recommended bypass surgery for this patients. However, all right, so we took a chronic angiogram again. So, Dr. Kang, would you introduce and discuss with how would you treat this one?
The patient was referred from other hospital, and we took angiography again, and you can show very discrete tight disease on the distal left main. And next.
All right. Oh, clear.
You can see that the very severe disease at the left main distal shaft, and then you can see diffuse disease on the proximal LAD and big the high diagonal branch disease, and circumflex osteum looks relatively safe in this angiography. Next. And this is the RAO cranial view. You can see the elongated LAD, and you can see the very severe calcified disease on the proximal LAD.
Diffuse disease.
Yeah, diffuse disease.
Fluoroscopic calcification on there. All right, would you show us previous one, spider?
Yeah. Previous.
Spider ones. Okay. So Alan.
Yeah.
What do you think about that one, right? High syntax.
Yes, in the US, I'm sure that, most of the folks will send them to bypass surgery because just the left main LAD disease, but she's relatively young as well. So, obviously I think PCI is a consideration, but I think here, complete revascularization is also important, functionally complete revascularization, meaning that we don't want to overtreat and we don't want to undertreat. So I think angiographically, it looks like obviously left main is tight, and the high diagonal sort of ramus-ish lesion is also looks like there's a fair lesion, and also the LAD has a long lesion sort of at this corner. So the circumflex, at least, there's some distal disease, very smallish vessel. So the target will be the high diagonal ramus, LAD, and left main. So that's kind of my first sort of read, is to sort of see where the action is. So maybe our panelists, anyone want to comment, where are the lesions you want to treat?
Okay, what about the, Japanese style? Dr. Takashi, Dr. Murasato.
Will our Japanese colleague do DCA here?
Yes, yes.
So-
In Japan, this is a candidate for the DCA. As you know, as you can see, the distal left main region is very discrete. So this is suitable for the directional coronary atherectomy. However, there is a heavy image, so predilation with 2.0 millimeter or 2.5 millimeter is necessary to stabilize the hemodynamics of the patient.
Yeah, I agree, Dr. Murasato. Yes, and geographically, the left main is 100, right? Yes, actually, there are some disease in LAD and diagonal and LAMS, but we can treat separately left main and the other portion. Therefore, we can focus on the distal left main first. And in Japan, some institutions like to use an DCA, and it is one of the good candidates for DCA, right?
Right. I think it done. After the TCA, you have to do the stent, right? Through stent for that,
Yes,
right?
yes, that's right.
Great.
However,
Chen, Dr. Chen.
Oh, thank you. Thank you. Very
Right.
great case. Good morning, SJ. I think
Good
it's
day.
spider view is very clearly to show the distribution. So as Alan said, distal left main. Actually, from spider view, I think it's not isolated distal left main. So the left main is disease from the ostium to the proximal AD. So my strategy will be to pre-dilate, use 2.5 the semi-compliant bone for left main, and then I will check IVUS for both LADs and flats. So even the osteals and flats looks good, but still there are some disease. So probably I use 2 vials, one LADs and flats, pre-dilate and check IVUS.
All right.
Hello, Park.
What the thing is, Dr. Chen, actually, you discuss about the two-stent, upfront two-stent technique in terms of our first diagonal branches, the proximal part, and there are some disease, actually significant disease, and so I'm concerned about the first diagonal branch. What do you think? Would you treat that one?
Oh, thank you. I think no indication for distal left main using two-stent technique in terms of the ramus. The osteal ramus looks like around 70%, but it's soon after the taking off, the proximal part of ramus looks very severely diseased. But for this patient, I think the target lesion should be the left main disease. So recently, according to our definition criteria, I will be reluctant to use two-stent technique for this case. Thank you.
Michael.
Hi, Dr. Park. Thank you for
All
asking.
All right. Thank you.
What I would do is I would IVUS the left main. If there is a healthy landing zone in the distal left main, I would try to land the stent without crossing over into the circumflex, without crossing over into the high diag. If there is involvement of the osteal LAD or distal left main, you're obligated to cross over. But if there is, by chance, a good healthy landing zone, maybe you could even land the distal edge of the stent in the confluence, the polygonal confluence. I would also IVUS the diag. If there is no severe osteodiag disease, perhaps you could address it without having to protrude the stent into the main vessel in the LAD. So I think IVUS would be very helpful.
All right. What about the Dr. Seung-Jea? Tahk is there?
Good morning, Dr.
All right.
I think that this is the left main lesion, but also we have a long diffuse lesion at LAD, proximal LAD. So at first, as Dr. Lee said, using IVUS, we can fix the left main lesion, and after that, we can move to the physiologic study to evaluate the another lesion in the LAD, proximal to mid LAD lesion. I think it's relatively long. Maybe it is physiologically significant, I think.
Okay, Myeong-Ki is over there.
Yes.
All right, so you have to finalize. How would you do that, right?
Okay.
All right.
When I listened to the comment from the panelist, first of all, most important of these cases is the imaging. IVC is very helpful. The reason why, first of all, what size of the left main, real main size, angiographically, in the region was located in the distal left main alone. However, the angiographic appearance in the mid-LAD or proximal circum, based on this size, the angiographic appearance of the left main is small. I don't think so. If we do the main, I think the left main size more than 4 or 4.5, or in the vessel size in the 5.
Ooh,
So
great.
is my estimation based on so second one is the disease status and the osteal of the intermediate branch and the osteum of the cell. And we have to confirm that what is the status of the disease in the by IVUS. And finally, when you look at the angiographic appearance of the RCA and the circumflex, the size of the vessel is quite bigger in the right coronary artery. So actually, and we cross over the circum from the left main to the LAD. Actually, the risk of some compromised vessel or hemodynamic disturbance is might be lower. So anyhow, we have to confirm that the right coronary artery is bigger, and even though there is some disease, but the hemodynamically insignificant. So when we fix it this region, we have a more comfortable than the real severe real bifurcation region with a big size of the cell. So anyhow, imaging is the first step. No doubt.
Okay, why don't you show us some imaging?
Great, right. So finalize, Dr. Kang, you can do as you want, right?
Yes.
So briefly explain what would you do that, what will you do that, and okay. Explain that.
I 100% with Dr. Hong's opinion. So let's check the IVUS first. Yes.
Sure.
I wired all three branches, left LAD and RI and circumflex, and checked IVUS.
No, 3 wires in it.
Yeah. Let's see the IVUS with the angiographic image. Can you see the
3 wires. Okay, good.
Can you see the IVUS?
Yes.
This is the 처음부터 보세요.
So I presume this is
Yeah, this is the circumflex run.
Okay.
Yeah. This is from the proximal circumflex, and circumflex vessel size about 3.25, and this is the ostium of the circumflex.
Big.
Yes.
Big vessel.
This is the distal left main, and you can see the ostium of the circumflex as you.
Ostium.
Yes. Here is the ostium, and you can see the vessel is the opening is relatively preserved with a good opening to the left main.
Okay.
And I checked the LAD. Yes, this is from the LAD, mid-LAD, and you can see very tight disease with the severe calcification with the superficial calcium. And here vessel size is about 3.0 and proximal, and you can see very tight disease with a heavy plaque burden, a little bit different from the angio, and with a huge amount of the plaque.
So size-wise, it's bigger than we, we've seen, we expected.
Yes, that's right. Yeah.
3 or more than that. Right?
Yeah, proximal LAD is relatively preserved, and you can see that high diagonal branch. It was not RI. High diagonal branch was coming in from the 6 o'clock, and the opening looks okay in this image. And this is the circumflex coming in from the 5 o'clock.
Stop it.
Yeah.
Just before coming in, anyway, the proximal LAD. All right, would you show the proximal LAD part? Okay. All right. Great. It looks good by angiogram findings. However, there are diffuse disease, continued to from the distal to the proximal LAD though. All right. Size-wise, just Dr. Hong expected more than almost 4 something. All right. This is okay. Go ahead.
Did you pre-dial the left main before I was?
In this patient, I did not pre-dilate because IVUS could introduce very easily, and the patient was
Okay.
very stable. So
Big
I
vessel,
just did the
left main, and
IVUS. This is the
what you show?
left main shaft, and the proximal left main and ostium. As Dr. Hong said, the vessel size is more than 4 in
Diagonal
IVUS
branch.
image. Let's see the final diagonal run. This is a diagonal branch IVUS. Vessel size is about 2.5, and here about 2.75.
More than that, right?
Yeah.
Almost 3,
And
2.75.
diffusely diseased with a large amount of plaque.
Big one, right?
Yes,
Than expect.
bigger than expected, and the patient had only one big diagonal branch and small another diagonal branch. And this is the opening of the diagonal. Yes, let's
Right.
review
Diffuse
again.
disease and some disease of ostium.
Yes, the ostium is a little bit diseased, and a large diagonal branch with a big territory. So,
I was finding Dr. Chen. What do you
Hi.
think? Stand or just
Yeah.
leave it?
Yeah, sorry, I still prefer to use one stand, provisional stand. So I will use the 3.5 from proximal ID to left main. But probably we need 2 or 3 wire. I think osteo flat looks good. Minimal lumen area is big enough. After standing
I
left.
think we need to treat the diagonal first. Let's call it ramus. We treat the ramus first. Teased all the way to the ostium, not crushing, because it's going to ostium may be okay to leave alone. So then you cross over left main to LAD. Obviously, the middle LAD needs to be fixed as well.
Still, right? You all very much conservative. However, recently, almost 2 years, right? If Dr. Chen is, we got almost same concept. If side branch is more than 2.5, anyway, there is significant disease. We do upfront to 2 stands. We're gonna compare with side by side, but a provisional stand. However, 2 stand is really good. Just Dr. Chen, definitions that suggest. So we really prefer upfront stand if the size-wise big one is more than 2.5. All right. So would you explain that one?
Yes,
What we've done?
So we decided to open the RI branch with the upfront two-stand technique. Next.
3 wire.
I pre-dilated the LAD with a 2.5 balloon. Next. And the left main ostium. Next. And check the angiography. Next. Yes. Next. And dilated the RI with a 2.0 balloon. I used the soft balloon because the plaque was soft at the RI. Next. Next. And we decided to stand with a two-stand technique upfrontly at the RI and LAD. We put the stand, 2.5 stand, and next, this is 2.5 by 18 giant stand, and next, inflated with a little bit small pressure, 6 atm next, and applied higher 14 atm at the proximal RI, and next, and next, and next, and crushed with a 3.0 NC balloon.
Balloon crush, right?
Yes, performed balloon crush, and further dilated the left main shaft. Next. And we are here.
All right. So spider view, please.
Yeah.
All right. Take a picture.
So how long? Just one question. How long protrusion of ramus stand into the left main?
Because in IVUS, there was some gap from the ostium of the high RI or high diagonal branch to circumflex. So I very small protruded the stand into the prox LAD because I believe that there would be some landing zone for the side branch.
All right. So we have already, there was some dissection, just a part of LAD, and so we have to proceed. Next procedures. What is that one?
This is the 2.75 by 38 stent.
We have already done balloon dilations with the portion of LED dissected area and the main, tightest portions we have already done with the 2.5 balloon high pressure inflation and balloon crush for the diagonal branches. And so we're gonna do just a stent crossover from the distal to the main here. There are diffuse disease. However, circumflex is just a kept wire. However, I think we don't need any, angle is very steep. So it's more comfortable.
I think we need further dilate the mid-LED region because it was very heavily calcified region.
Don't push too much.
Yes. And I need NC balloon 2.5.
2.75.
NC.
2.5.
So, SJ, just one question. I was confirmed the proximate diameter of diagonal is around 2.75. So we deployed 2.5 stent. So before balloon crush, do you routinely post-dilate the side branch stent?
All right. That, right, there's options. Just you mentioned of the DK, right? Kind of,
No, not only DK, also for consequence.
Okay, nominal. Yes. After the stenting,
there is
14, 15,
there is calcified region,
16, 18,
high pressure,
deflation.
more further.
Yeah, touch 20. Okay.
It's just a matter of sequencing. So I think the other option is to fix all the LED, proximal LED, mid LED, and distal LED first before the ramus. So at least you don't have a little stent sticking out. Sometimes it rubs against the new stent going in, makes it a little harder. So because there's such a long area and near the ramus is not that disease. So if you fix it distal LED first, you can still work on a proximal part too. So that's another sequence you can do if we don't pre-dilate the ramus first. So now you can concentrate on the proximal part. So hopefully the stents will be slide across now.
All right. Push in.
Yes. Now you cross.
Great.
Where?
Just please.
Test.
You go for
What is the stent size that you put?
It's 2.75. Because the
2.75?
distal,
Yeah, 2.75. Match it with the
John
distal
was
part first. Test, please. What do you think?
Okay.
Ostium, main. Again.
Test.
Just what is it? It's okay.
좀 더 나오겠습니다. A little bit. Test.
Okay. I think it's good.
I don't know the stent brand because left main diameter is more than 4 millimeters. So this is 2.75 stent. So it's possible to dilate to up to 4.
Yes.
올라갑시다.
This is the Zion. Sierra.
Sierra. And the 2.75 stent can be dilated more than 4.5 in this version. Deflation. So because
that is another merit of Sierra.
Yeah.
So I match with the from the distal to the proximal.
Yeah.
Different size. Okay.
14, 16.
2.9.
18. Deflation.
How about this landing zone?
Just above the second diagonal branches. Just normal looking area. So still there are some disease. However, all right, that one. I'm finding it.
I think so. The additional stenting is necessary for the distal landing zone. There is a moderate region in the middle area.
Portion,
yeah.
There was also some disease on
I think 3.0 millimeter, 2.75 millimeter long stent in the middle LED and 3.5 millimeter stent should be located the left main to the proximal LED. So two stent.
That is the another option.
Than this, yeah.
I think so.
All right. You want to show what happens after
the landing zone.
All right.
Okay.
Go ahead. Great. Some focal disease, very distal part, landing
Yes.
area.
And proximally, this is the landing
All
zone
right,
of the
good.
stent.
I really like this one, right? Just based on the obvious finding.
And we need
All
further
right.
dilation.
275 is still under expansion. All right. So if stent area is, what is that?
Yeah, I think
What's wrong?
I think you need to use a 3O NC balloon to post dilate.
Yes.
Right?
Now stent is under expanded.
Okay, right.
Yeah.
So
So
what
we
do
need
do
further
there?
dilation.
3O,
Density
3O,
balloon.
approximately almost 4.
So how much is the minimal lumen area distal to stent in AD?
All right, so we want to maximize as a stent diameters after the stent placement more than 2.5 means at the least of 5 millimeter square. So I think that may be quite enough. So we're gonna do 275.
This is
3O.
3.0
Okay.
NC.
3O non-compliant balloon. Oh no, be careful. Okay. Good.
Okay. Distal edge size was about 2.8 and it was very expanded. So
Great.
a little bit inside nominal.
Right.
I will inflate the 3.0 balloon.
Right.
14, 16. Deflation.
Approximately. Okay.
20,
3.2, 20, 25.
24.
Calcify the region over there.
Deflation.
So Alan, usually how long post dilation? 15 seconds or 20 seconds or 5 seconds?
All right. Good
14.
suggestion.
20.
Would you
Relatively
consider
long
taking
duration.
the wire out of the
Long duration.
circumflex right now so you don't
Duration.
gale it some more?
Yes, I will inflate the left main with the bigger balloon. Before that, I will remove the
no. All right.
Yeah.
Inflate.
Yeah.
Why not? There is some discrepancy between the ostial part of guider and
Yeah.
stent. So you have to dilate force
Yes.
at the main area, right?
Before that, I will remove the circumflex wire.
All right.
Yeah. Test. The circumflex opening is very
All
good.
right. There are some problems with
Yeah.
distal part.
Check angio.
Yeah.
Nitro.
Yeah.
Okay.
Let's check
Angio first.
check angio.
All right. Would
There will
you
be
give
some
me balloon for
dissection.
that? Balloon?
Yeah. Balloon 2.5.
You're on. Compliant. All right. 3-0. 3-0. Fasting.
Yeah.
Balloon for
2.5.
ready. Distal part
Yeah.
balloon.
Chen mentioned about the duration of high pressure balloon for the calcified lesion. So depends on the Japanese data. So if we have more tough lesion, or longer duration is beneficial. Even with the same pressure. Yeah.
Recurrent inflation is better.
Nominal.
So 20 seconds,
Okay,
3
wait.
times is better.
Yes.
Then 60-second inflation. So recurrent 3 times inflation is recommended.
Deflation
Deflation.
들어가서 long duration
Yeah,
inflation.
deflation.
Deflate and a little bit further.
Longer and frequent, more times.
20 seconds and
Nominal?
3 times at
Nominal.
least.
Okay. All right.
So
nominal
maybe
and
it
long
crash well,
duration.
recurrent kissing balloon inflation for the bifurcation is effective to the acquires enough stent area. So recurrence of the kissing balloon inflation or recurrence of the high pressure ballooning is useful for acquired room
Yeah,
for
contrast.
acquired stent expansion.
Further distal.
And
6.
Then in this case, is
disease over there, right?
from the beginning, it's better to divide the lesion with two parts. One is LAD lesion, and the other one is main lesions with different size stent.
Okay.
Deflation.
So it's better to treat and select stent length and stent size.
Recover.
All right, there are some, problems. Just the distal part of our region. Actually, we don't want to do the stent for the mid-LAD, right? And there are some diseases. However, after the stent procedures, we want to show anesthesia FFR for that one. So, however, there are maybe some mechanical, traumas during the distal part of a high pressure inflation. And so we did just compile, solve the balloon inflation for that, good patency. And so after the main, non-compliant dilation, we're going to do distal part.
Yes.
So what we have to do.
There's resistance.
Actually, these cases include two parts. One is the distal left main bifurcation region,
Right.
and the mid-LAD with severe calcification. I think that the flow disturbance is at the mid-LAD is maybe partly by the severe calcium with some dissection. So the retrospectively, when we meet these cases maybe in the future, the treatment strategy was as Dr. Murasato recommended is fix it the mid-LAD is one stent and more distal covered, and then approximately more bigger size of it.
All right. Finally, we have to accept your suggestion. All right.
Yes. With a 4.0 balloon, I will inflate the QC area.
Proximal LAD is almost 4, right?
Yes.
Right.
Nominal.
All right. Great.
Proximal ID almost 3.5, I think.
Is it a high pressure 4.0 balloon? Yes.
4 balloon.
Yeah. And
okay, great.
Main.
High pressure.
Further. 16.
Too much. All right. Good.
Okay.
I like it.
Yes. 18.
What pressure?
18.
Another
20, long duration, right?
Yeah.
All right.
Educational lesson of these cases, the right coronary artery is bigger, and in this kind of the left main, the procedure itself is quite stable. For the circum distribution is quite lesser.
I think we're gonna push in balloon, all right, for the just cross the
right coronary artery is dominant.
We're gonna do relatively intermediate pressure. Why not push in balloon a little bit further?
Yes,
slowly.
So I think can you move to spider view?
Okay. What is the nominal?
12.
Why not 10 pressure? 10.
And based on my experiences, when we put relatively small stent in the left main, I think before another procedure, dilate the left main stent more with bigger balloon. Before every procedure, it's very important to prevent the crushing the left main stent with guiding catheter. So it is very important to approximate the left main stent before any other distal procedures. I think it's very important. It makes it more safe procedure and more easy to access the distal areas.
Yeah, especially left main proximal optimization take part is effective to oppose the proximal side, and the pot balloon should be located bifurcated carina with this marker. So the spider view is the necessary to identify the
we're going to see that what happens slowly, and then
this is the distal lesion. Distal
All right.
Hematoma and also dissection.
Right.
6 o'clock.
We need the another stand deployment
Yes.
and distal to the
Alright.
stand.
All right, why not? Automatic.
Yeah.
Pull back.
Pull
We
back.
want to see what's happening. The distal part. Okay, good. Far distal 2 something.
Yeah, here's normal.
The reason why is we want to touch for that. 2530.
Yes, there was some balloon related dissection. You can see the flap.
At least 30.
Yeah, the size is 3.0.
All right, that is the side, the dissected. They're pretty much flat over there. Right?
Yes.
It's small here, yeah.
There is a typical appearance of the hematoma.
Hematoma.
Rear.
Yeah.
And jaw, all right.
Yes, the calcified region.
Dissection.
Just distal.
Dissected plaque of
Yes,
the 12. Big vessel, 3O. And stand. Placement is perfect. I think it's really like that one. Stand diameter is almost 3.
Yes.
The meaning is, the stand area is more than almost 7. The
Yeah.
eccentric area still, there are some difficulty to the push in the ibis costa. We have to consider small dilation there. However, there is focal calcium, so we have to consider a kind of a rupture or something like that. 275 non-compliant high pressure. We need that, and then so maybe it's some difficulties to pass the undilated region. So we need a
More
dilation, right? Doro guiders and push in the another stem for that. All right, that is proximal. Circumference take up from. You really worry about how much big is stand diameters. Even we use a 2.75. However, it is big enough to match the main diameters, almost 4 more than that, and so we don't worry too much about it. 2.75 a single long stand can match with a small to large main vessel too, right? Okay, so
Could you check the proximal side of the stand? Could you check in the IBAS? You have not yet checked the proximal side, proximal edge of the stand.
You mean the left main ostium?
Yeah, IBAS. So guiding catheter disengaged and please check the proximal end of the stand.
Yes, at the last of the procedure, I will check because I engage with the guiding.
Okay.
Okay, take a picture first.
Yes.
Because of time, we are thinking about moving to the next
All
page.
right, great. We are going to show them the final results. Don't worry, right?
Yeah, actually, before that, I'd like to say one of it. When you fixate the distal portion, you should choose the more longer stand length.
Yes. Okay, great.
To cover the intramural hematoma.
Okay, we're going to show that. What's happening later, right?
You're going to do sort of rewire the ramus and then do kissing and as well, right? At the end.
Of course, right.
Good. So because of time, our team was telling us to go ahead and go to the second case. So if there's time, we can come back and see how you're doing.
Okay, hello. Hello.
Okay,
Ellen. Yes, it's good to see you. This is our second live case demonstration. We are very happy to conduct the first web-based, Zoom-based live case demonstration and discussion. This is, I think, a very nice chance to see the live case demonstration in COVID-19, the pandemic. So I'm going to introduce our team and Professor H.B. Park. I'm D.W. Park, and our senior fellow is Joo-Hyun Kim. We're going to start our case, the briefing. Could you introduce patient background?
The left main bifurcation case. 66 years old female admitted for DOE, started for 5 months ago. Her chronic factors was hypertension and hyperlipidemia. And coronary angiogram showed diffuse severe stenosis at RCA and left main bifurcation disease. Next. Her clinical presentation is stable angina. Next. Her echocardiogram showed normal LV system function without regional wall motion, and her left coronary angiogram shows severe left main bifurcation disease. And right coronary angio show diffuse disease at proximal mid-to RCA, and syntax score is 45 points. Next. 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 Last week, we treated for her proximal mid-RCA by stenting. And today?
Okay, so, and if I'm going to summarize this patient briefly, in 66, relatively young woman, and the hypertension, hyperlipidemia, without no diabetics, and previous syntax score is very high, and we already treat the right coronary artery. And looking at this is the RAO coral view, and you can see, can you see the coronary angio?
Yes.
Okay, and there is some significant stenosis left main ostium. Also, sulc ostium. There is common sulc and a big Lamus branch, and angiographically looks okay. And next view. So this is the epicranial view, RAO cranial view. We can see how much is significant of left main disease. There is some eccentric calcium, also a prox part, a mid part. There is some heaviness, and the next one. And then this is the spider view, and the spider view some different story. Distal left main, and the RA view looks like 110, but the spider view is 111 or 110, and we don't know. So at this point, I'm going to discuss after seeing all the baseline angiography, and we know the baseline, the characteristics, and what is the strategy for how do we treat the distal left main disease before IVUS, and we already checked IVUS.
I think this lesion is also very significant disease from distal main to the proximal LAD, and then also including circumflex os. So very important branch circumflex is. So let's go to the two-stent technique from the beginning. I think is better. Yeah.
So I think the ambiguity from the angiogram is the origin of the circumflex ramus, because they join together first before they come into the. So you can call it a high OM as well, and also the disease seems to extend more into the true circ than the OM. So I think imaging to really define those ambiguity will be very helpful before, and also the disease into the left main. Into the LAD is quite extensive. Like the case that we just talked about, we want to make sure that we address those distal calcified lesion and before we could tackle the more proximal area too.
Yeah, so I think this is a very nice time, this interactive time. This time is a worldwide famous imaging specialist join, worldwide famous physiology specialist join, and technique specialist join. And I think this is a very nice time to discuss the imaging is required or physiology required and the decision-making process. Shaoliang, Chen, any comment for this case?
Yeah, thank you. I think it's a very great case. So from spider view, so the lesion could be defined by Medina 111. If for me, I will do not use two stent. The two reasons. The first reason is RCA is dominant. Second reason is the lesion at the proximal circumflex looks like around 5 to 7 millimeters. So I think it could be defined as a simple bifocal lesion. So for this, of course, we need an intravascular imaging.
Definitely.
Of course, I prefer to use a provisional with drug-coating balloon for circumflex.
Yeah. So, and Professor Akasaka and you and Professor Murasato, you are imaging specialist, and how do you think for this lesion?
Yeah, the key issue is the CX orifice, right? If there are a good lumen area, we can just put the crossover technique one stent. But if there are a disease at the proximal CX, two-stent strategy should be ideal, right? So the imaging of the CX orifice is very important in this case.
Yeah. And okay, go ahead.
In the fluoroscopy, the calcified region is located in the left main, especially as left main ostium has a nodule-like, so tight region is would be located at the left main ostium. So I think the ablation is necessary for the left main. But however, the SX ostium does not have the calcification in the fluoroscopy, I think. So checks ibis city is very important for the SX ostium. However, I think the ablation is necessary for the left main.
I agree with Dr. Murasato. The angiographic appearance, I think it's personally, it is really tough cases. Not the great cases, really tough cases. For the easy or comfortability for the next step, to stand or a provisional stand. And now we have to be the procedure itself is easy to and simple and comfortable. But the angiographic appearance, heavy calcification is expected, and the best course is tortuous. So it is not easy to the procedure itself. Second one is a stent expansion might be the underexpanded if we do not ablate the region from the distal main to the proximal LAD.
Okay, it's a very nice comment. So I think this case is a typical representative case of why we required imaging evaluation for left main intervention. You know, Excel trial, I was used the 74, Noble trial 76, and our previous pre-combat trial used 78%. But in the real world and the European Western countries, still overall IVUS penetration still less than 30%. In our center, we usually almost all cases do IVUS evaluation, especially for complex PCI. Okay, we're gonna show the imaging, and this is the SOC. And could you show us the IVUS imaging? Okay, start over here. This is the SOC part, and this is the distal part of the true SOC. Okay. Okay, this is the SOC part. Here is the vessel size is 3.0, and also here is the ostium of the SOC. Could you show us the you know, looking at the plug was located of the lateral part of the SOC ostium, as you see, and the lumen diameter is at least 3.0. Plug is very heavy, so more than 80%, and definitely on the basis of the IVUS, we require two stent. We cannot treat well with the provisional stent, such like a heavy plaque burden and also some eccentric calcification. Also, we checked the LAD, the IVUS. Could you show us the LAD? Okay, IVUS. LAD IVUS 한번 가볼까요? Yeah. Here is there is some proximal part. There is some heaviness. Proximal part of the heaviness. So we did, you know, pre-dilation. The IVUS does not pass well the distal main part. This is the prox part of LAD. We can see lumen is 3.0. Plug was encircling. Lumen area is less than 2.0. There was a heaviness portion. Also, plug was extended prox LAD. Could you jump up to the distal main? 조금만 더 빨리 가볼까? 시간이 제한이 있으니까. Okay, here. Okay. The prox LAD. 그 조금 더 play again here. This is the prox LAD. Okay, there is some calcium. The calcium over here, and the initial pre-dilation IVUS evaluation is not working, and we did pre-dilation using the non-compliant voluntary function. This is a coming of the SOC ostium. There is some heavy plaque. This is a distal main, and we did pre-dilation. There is some dissection, and we can see, as many moderator panel mentioned, there is some eccentric calcium, and the plaque was absolutely extended to left main ostium over here. This is left main ostium. You can see the huge plaque was definitely extended to left main ostium. So, and after seeing the IVUS whole evaluation, any thought and any comment and any change of the technique?
What is the lesson of the? the IBIS imaging is Dr. Park said that initially try to introduce the IBIS caster without the predilation, but the caster was not passed through the lesion. It means it is a really severe calcification. So therefore, that is the message is okay, it's time to the load ablation without the predilation, and then to a load ablation and the balloon dilation and do the IBIS is the appropriate the sequence of the step.
Here is the part is IBIS does not pass well over here. You can see the tip of the IBIS does not pass.
Yeah.
On the IBIS, the circumflex stenosis is very severe, but very short.
Yeah,
very
right.
short. So
very short. Yeah.
I think that we have the two options. One is from the beginning by side branch stent first, but it is very short lesion, so we can go to the protect the circumflex, but go to the provisional decision strategy, I think. Yeah.
Yes.
Very short, yeah.
So is your wire in the circumflex in the OM, or is it in the true circ when you IBIS?
It's the OM, yeah, big OM branch.
Because your true circ has quite a bit of disease beyond the OM too, right? OM.
Yeah, right.
Question, and that's not a small circumflex. So you decide if you want to treat that, then I would do 2 stents because it would be hard for you to go back in that angle. You want to leave that alone. So see that turn here that there's in that corner. So
yeah, right.
You want to leave that alone, obviously. Then you know that is a very short proximal.
Yeah, right. Yeah, that is very nice point. That we decided to OM branch is also big and the circle branch is also big, and we decide to the more smooth angle in the OM branch. So we made some progress, and okay, so we are definitely on the basis of the IBIS, we decided to shorten the OM branch, the balloon stent, and we performed the predilation using 3.0. This is a non-compliant balloon over here, and next one. We already put the distal part, there is some heaviness, a huge plaque burden. We already put the 3.0 26 leisure stent. And also we're gonna do now is a most critical part is a distal leg main stenting. So, okay. So, and we decide to short stent 15 and 3.0 in the circle ostium. This is a non-compliant balloon at 3.5 over here. I'm gonna put the non-compliant balloon over here. And then I'm gonna put the regular stent 3.015, and although overall lesion length in the circle is just 8, we prefer at least 12 or at least 15 the stent the length over here. Okay, 약간 조금만 넘어간 다음에. Okay, fast well, and then spiral view. 오케이, 이거 조금만 조절해 주고요. 자, 볼게요. This is the NC balloon, and then 자, 여기서 we should focus on this. 자, 들어갈게. 조금만 더 나오고, 자, 조금만 더 나오고, 자, 번이, 자, 오케이, 여기 다이 테스트. 오케이, 자, 한번 찍어보자. 이거 찍고, 엔조 레디. 자, 풀샷. 오케이, 조금만 더 나올게. Slightly more pullback. 오케이, ready. 자, suck. 자, 테스트. Okay, I think it's good. Okay, go. Suck. This is 3.015. Okay, 12, 14. Okay, say
resolute.
Yeah, resolute. Yeah.
Technique.
Yeah.
Well, as you know, resolute proximal part has the mooring.
12, 14, 16.
I think the crash stent is not suitable for this case.
So, and there are I know there are a lot of debate about which contemporary drug-eluting stent is the best for distal main stent. So last year we published the JACC, and we compared the Giants, the Resolute, Promos, and the several different type of contemporary drug. in terms of outcomes, there is no difference. So I think according to preference of a physician, is the contemporary, any type of a contemporary drug lowering stent would be good for the distal and main. Okay, I'm gonna over here.
Murasato sensing means the
nominal
the-
12,
the
14, 16, 18.
resolute is not
Okay.
suitable for the side branch, you mean?
Yeah, proximal
20.
part of the resolute stent has more link connection.
More connection.
Okay.
So,
Yeah,
stent
so
3.5.
so you don't
minimum
you did not
protruded-
mention the left main, mention about the side branch stent, yeah?
Yeah, generally
Yeah.
speaking.
Should,
So
okay.
protruded length should be longer than a giant stent or arch muscle stent. As you know, the synergy stent and the resolute stent has more link in the proximal part. So protruded length should be longer than the other giants or arch muscle stent.
Yeah.
So in such case, I prefer the giants or arch muscle stent.
Oh,
So it's more hard to crush it. More hard to crush it with main branch stenting, yeah?
I just want to check with everyone that we're going to go over maybe 10 minutes or so, if everybody's okay to stay on, because we want to finish a significant part of this case and maybe go back to SJ's room.
Okay, good. Yeah.
Okay, so if everybody's okay, we'll go over maybe 10, 15 minutes. So please stay on with us.
자, 뭐 부스터 한번 써볼게. 부스터에서, the booster is very helpful to decide some overlapping portion. So we frequently use the booster. I don't know how much radiation is booster. Okay, this is area of cranial view is very helpful to fully cover the left main ostium. This is our really standard view to cover the left main ostium test. Okay,
So is this your favorite view?
Yeah, this is our favorite view. Okay, test. Okay, 조금 더 들어가야 되겠다, 그지? Okay. 자, test.
I think it's fully,
okay, test.
fully cover.
Yeah, over here. And then we are again use the zoom booster to see the cover. 조금 더 들어가야 돼. 야, 이 너무 아슬아슬하게 맞네. 자, 테스트. 자, 한 번 더. 테스트. 그치? 지금 들어갔지? 오케이, 테스트. 자, 조금 더 나올게. 자, 한 번 더. 뒤에가 테스트. 자, 고! 가자. 12. 그렇지. 12. 오케이. 14. Okay, save.
Hi, it's Michael. So there was a question whether you should have done atherectomy. Just looking at the IVUS, I think you made the right decision. There was maybe 5 millimeters, 10 millimeters most where there was circumferential calcium of more than 270 degrees, but for the most part, it was eccentric calcium, less than 180 degrees of degree of calcium. So I think the fact that your balloon profiled so well, I think it was a very good decision.
Yes, and then I'm gonna do the NC balloon dilation is the LED part, and then I'm gonna do recross the circle wire. This is a 3.5. Okay.
So, Dr. Park?
Yes.
So are you very generous to allow the protrusion of stent
yeah, right.
outside the left main also?
Yeah, it's not much generous, slightly generous. Yeah, and the 2 and 3 protrusion is okay, but it's usually I'm gonna try to exactly.
Try to fix.
Yeah, try to fix. Yeah.
Fix the lesion exactly, but sometimes too much exactly is we cannot. We sometimes we miss the.
Yeah, definitely. Yeah, that is a very nice point. Yeah. And then over here.
Well, you can see the ostium. If you really.
3.0 맞지? 작게 가자. 좀 보시죠. 자, 고 4, 5.
Exactly at the origin.
7. Okay, save. Deplete. This is 3.5 NC balloon. 자, okay, go 6, 8, 10, 12, 14.
In cases of a little bit long extrusion of stent out.
6, 8, 10,
outside
12,
from
14,
the left
16.
main ostium, so
Okay,
you
save. Deplete.
you prone you go to the prolonged dual interplatelet or not?
Yeah, usually, and nowadays stent is much better compared to first generation drug-eluting stent. Also, many study performed in Japan and Korea stop depth trial, some of trial shorter, even though complex PCI, shorter depth is okay. So usually for distal left main and the cross stenting to stent, at least we're gonna keep the at least 1 year, and then depending on physician discretion. Some physician prefer 2 year, and SJ nowadays choice is after 1 year he stopped the aspirin and just keep the Plavix alone. Yes.
So this kind of complex lesion, you recommend at least 1 year.
At least 1 year. Yeah. Okay. Save. Deplete. 자, 20. Okay. Save. Deplete. Okay.
There's a gap between the two stents, right? Don't work. I don't know for sure.
We're gonna check it. Ibis.
Ibis,
자, 20. This is some hanging out. Okay, save. Deplete.
Dr. Chen, is there any thought of comparison with DK crush with regular crush? Do you think there's any difference?
좀 갭이 있나?
Yeah,
있으면 다시 해야지.
yeah, we compared from our first trial, compare DK with calcium crush. I think the final results favor the DK or calcium crush.
And what was the main difference? Was it in TLR, TLF?
Both. TR understands thrombosis.
Really? Okay.
Okay.
Because after calcium crush, there's 3 layers of stent.
Okay.
In almost all the meta-analysis of the bifurcation lesion, DK crush is a very important factor to improve the long-term effect, long-term result. Yeah.
Yeah,
it is main technique, DK crush.
So at this, and geographically looks okay. I'm gonna at this point recourse the sock wire, and then finally the kissing, and then evaluated IVUS whole segment. I think there is some suspicious gap would be, and if there is some gap and we require additional stent over here, I'm gonna 잠깐만 찍지 봐봐.
Yeah, looks like they have 1 millimeter gap.
아, 볼륨이 없으면 안 보이는구나. 그냥 찍어보자.
So I think can you check IVUS?
Yeah. Okay, got it. 자, Y 한번 줘봐. Y 먼저 하고. Okay. 자, this is Xion blue. 자, 우리 보자. Introduce.
So diagonal branch that may be occluded, little bit in the axillary.
Yeah. Okay.
Staining of dye.
Yeah, patient is okay. And 자, 에피크레니얼 한번 보자. 얼마나 사이즈 컸는지. 처음에 뷰. 오케이. 브랜치 얼마나 컸는지.
How about the left main ostium? So severe calcified region. So stent expansion is maybe flattened type. So oval shape dilation.
We finally, and we're gonna do finally part, after kissing balloon dilation. Side of you. Okay, so and this case key lesson in the how much important IVUS evaluation when you do lemon PCI is that this is very important to decide the stent type technique 1 versus 2 stent, as well as the stent related any complication during PCI, and to check some not overlapping or overlapping, also optimization of the lemon part. Okay, test. This is a Xion blue wire.
Can I just ask the panel and everybody, is there any advantage of doing pot first prior to kissing balloon? Perhaps if you do pot first, it's easier to maybe get the wire into the side branch and advancing the second balloon to the side branch. Any thoughts about pot first?
Yeah, part first, I think. Part, side, kiss, repart.
Yes,
You
I
do part and
agree.
refart.
Like in California, pot all the time.
Not for
Before you pot and after, in middle you pot, and then after you pot again. So
However, even in the
save.
imaging, we evaluated the
그러면
set expansion
우리가
before final part.
본론을 3.0 나온 거
maybe
아까 본론
30%
나온 게
of the
뭐가 있지?
case should be
3.5 하나 해놓고
underwent the
저
part.
LAD에 나온 거 그다음에 2.0
other 70% of the case, it is not necessary to perform the final part.
이
And then the
3.5
imaging.
3.5
we're gonna
Yes.
go over to SJ's case to
Okay, great.
result, and we'll come back to hopefully see.
Okay, wonderful. Okay, wonderful.
Right back.
Okay.
Hi, SJ, we're coming
Oh,
back.
Alan, okay. We took a lot of effort to fix the distal part. Just Dr. Murasato suggested we have to do distal stem first. However, we respect the functional aspect, and not too much tight stenosis. However, technically, some dissected hematoma with distal part. And so, okay, Dr. Kang,
Yes.
also explain all the things, right?
Yes,
What you've done.
Yeah.
All right.
The dissected area was very had very tight stenosis with calcification, very calcified region, so very difficult to cross. So I used the Godzilla next. With the guidance of the 2.5 balloon, I introduced the Godzilla to distal and next. And as Dr. Hong as Dr. Hong recommended, we implanted a longer stent than expected to cover all hematoma and dissection. This is 2.5 by 33 stent. Next.
7.5.
Yeah. Yes. 2.75 by. Yeah. Next. And inflate. Next. And after IVC evaluation, I further dilated the stent with the 2.5, 2.75, and 3.5 at the proximal for stent optimization. Next. And with finishing the distal lesion coverage, recover, and
High pressure.
I restarted, yes, high pressure next.
275.
Yeah, this is 275 up to 28 ATM. Next, to open the calcified lesion. Next.
Almost we did, 25 atmosphere.
Yeah.
First 375.
Yes.
High pressure inflation for the focally undilated region, right?
Yeah.
So morphologically, angiography getting better. All right. Then
There was another 3.0 balloon anchoring, and rewiring was relatively not difficult. And this is BMW wire rewired to diagonal branch, and 2.0 compliant next, and 2.5 NC with the post optimization of the diagonal branch next, and next. And after high pressure at the diagonal branch with the 24 ATM, and another high pressure to main branch, because main branch is important. I applied very high pressure for main branch optimization. Next. And this is a kissing to 10 ATM next. This is a kissing next. And as Dr. Chen recommended, we apply the kissing balloon at the left main to optimize a huge left main vessel. Next. And
this final?
Yeah, that's final. Next.
Right. Spider view.
Next.
Would you show us previous one, spider?
Yeah,
all right.
Yeah. 다음. Yes.
All right, great, right? Actually, diagonal branches and crushed area is good. Circumflex system is perfect, right? I really believe there are some disease, minimal disease. However, the angle is very steep. In those cases, we don't worry too much about, compromise, degree of compromise. Circumflex is perfect. Okay, next.
Yes, this is final. Previous.
Next. There is area view is final, right?
This is final view. With
Hello.
the IVUS, we covered all dissected area.
Yeah, so I presume IVA looks good, expansion is good, so very good.
Right.
This illustrates.
I have one comment about the treatment of the intramural hematoma.
Yes.
Actually, the first one is a selection of the longer stent cover, and the final the displacement of the distal edge of the stent should be at the normal segment, and do not high pressure in the hematoma segment. The reason why hematoma was usually occur in the normal segment. So stent deployment just touch, just do not apply the high pressure. It creates the distal propagation of the hematoma more distally.
All right, great.
Is it frequent to high pressure progress the hematoma to the distally?
No, not too much.
Dr. Hong?
Yes.
So the do not give the high pressure means to prevent the progression of hematoma to the distal part.
Actually, it is if you do the high pressure in the hematoma segment, first one is the chance of the population, and the second one is squeezing it the distal propagation. So usually nominal pressure.
Do you believe the high pressure when we do the high pressure, there is increasing the chance of rupture with hematoma?
I think so.
I don't think so.
Because actually the hematoma segment is not a disease segment.
I think
it's a normal vessel wall segment.
Maybe it is not usual, but in this case, the giving high pressure is very important because it included very calcified lesion, and that's the
No. What I mean is that the hematoma segment does not have a calcification.
You mean
it's normal segment.
Okay.
Great. So we have to compromise in terms of distal part, normal looking area, stenting zone. We didn't do the high pressure, right? Just nominal pressure in 275, and just Murasato suggests in the calcified lesion area still there are too much plaque. There's some calcification on there. So there we did a high pressure inflation, right?
Right.
So it's great. Great suggestion and great discussion. This is final angiographic result, and so would you show final IVUS too? Okay, why not?
Yes. This is final IVUS.
IVUS
from the LAD.
LAD.
All
right.
Yeah. One more choice for lung hematoma is to use cutting balloon distally to avoid more stent.
If you cannot stent, that will be help to release that. But I think stenting probably is safer. But as Myeong-Ki said, I think long stent is the more important.
Dr. Hong suggested we deploy the stent distally normal looking area and just not too much pressure. 275 stent in nominal pressure. The reason why is we want to have a 2.5 stent diameters, at the least a 5 millimeter scale stent cross sectional areas. I think is quite enough especially for normal looking area. 5 millimeter scale is quite enough. Stent effective stent area, right?
Here is the
previous calcified region. So we did high pressure inflation.
From here,
still 2.5 something less than that 2.5. All right. We don't do the more high pressure for focal calcified undilated division. Just the high pressure, relatively small balloon, non-compliant, high pressure, that's enough. So we don't do I don't want to, a rupture or something like that. All right. This is approximately, what is it?
Yes, this is the approximate lesion, and the minimal stent area is about 7 or 8. And approximately there was some eccentric calcification, we've tried to fully dilate the lesion.
We do almost 25, 28 atmospheres. So, however, the eccentric calcium is not fixed up, so we don't do any more pressure for that.
Yes.
All right.
And this is proximal LAD, and soon diagonal branch is visible.
One, two,
is
three,
already
four.
larger.
Almost 4.
And the diagonal branch comes in from the Jokra, and there's almost no carina. And the circumflex ostium is visible. As you can see, it's widely opened. And this is the main tightest area is well opened. The lumen area is more than 10.
We use the basically 275 stent, right? Sierra. You can dilate is almost more than 4 millimeters. So the reason why is we prefer the Sierra. It's matched with a small vessel, with a big vessel. All right, that is osteopod. Just precise position, stem proximal.
Very nice position.
All right.
Great.
All right.
Excellent.
That's it.
And Dr. Khan, thank you very much.
All right. Great. Great.
Excellent.
Great job.
As well. So
Alright.
it makes it more sort of instructive and educational for us. Thank you so much.
Thank
Thank
you.
you.
Thank you.
Jung-wook for the closing for the other case. Thank you so
Yeah.
much.
Okay.
Hi,
okay.
we're back.
Yeah, okay. We're gonna show us this is the last view. Okay. Could you, as you mentioned, Alan, we did the final kissing balloon dilation using first LED anchoring 3.5, non-compliant balloon. Initially, we passed 2.0, small balloon, and then we did kissing balloon dilation. Suck is a 3.0, NC balloon, LED 3.5, NC balloon. We usually do sequential high pressure balloon dilation and the final kissing and the pullback kissing. And we did IBUS evaluation. As you mentioned, Alan, so we, evaluated the overall part of the LED. There is one skipped a bit of the metal over area. Okay, 그 전에서부터 보여줘볼까? Okay, over here. Okay, this is the digital stand. Over here, there is some strut over here. Over here, this is one missed part, but I think a lumen is okay. So there is no plaque rupture like that. I think it's just a little bit around is okay. So, and could you show us the proximal part of the circle 들어오는 부분? 자, okay, go. This is the crushed part. Circle is coming over 6 o'clock. There is a wide opening of the circle. Also, we're gonna show us the left main ostium. 조금 더 빨리 와서 left main is slightly protrude, hanging out. Is 2 or 3 the stand segment. 조금 더 빨리 와야 되겠다. Over here, okay, here, okay, play. This is the 1, 2, 3 hanging out. I think I fully covered the left main ostium. Could you show the circle ostium of IBUS? NGO 아래 코달 Y 다 빼고 준 거. Okay. This part is very expanded, and this is 3.0, and coming of the added ostium. Our IBUS criteria 5, 6, 7, 8 is fully, we've acquired. This is the final NGO view, area coral view. We can see the Lamus branch and Sucker branch is okay. And next one. This is the spider view, and the spider view looks beautiful. And the last one, this is the epicranial view. It looks beautiful.
Nice.
Yeah, I think that this result would be sufficient for this patient.
I have one comment.
Okay.
Could you show us the area caudal view?
Okay.
And
area caudal view. 전에 거.
The angiographically, it looks very excellent. But the
전에 거?
No. The area caudal view, okay.
Over here.
You see,
okay.
did you think there is a little bit of the neocarina creation by the stent strut? When you look at the angiographic appearance, a little bit dense appearance around the carina, and it is clearly shown in the IBIS finding in the left main bifurcation. Actually, there is the IBIS pullback 3 beat. 1, 2, 3. There is the stent crossover in the above the sarcom ostium. The reason why, actually, what is the ideal appearance of the bifurcation region? You try to the total absence of the stent strut above the ostium of the circ. That is the best one. But the current result is quite reasonable, quite very excellent result. But ideally, you try to the total absence of the stent strut above the side branch ostium.
Okay, very nice point.
Yeah, I fully agree. Yeah, so from angiography, it's also
Next
right.
slide,
Some flares from distal cell. So this is the typical appearance from the epicaudal or iocaudal to show the neocarina. Also from IVUS, I think the osteo some flares is not perfect. So if me, I will use 3O short non-compliant balloon insert and another NC balloon in ID to do one more case. Thank you.
One technique I've adopted is that when you have about 2 or 3 millimeters step into the aorta, when you have to re-engage, it may be more difficult. So sometimes I get a 5O balloon just to kind of flower it out just a bit. It may help re-engagement in the future. Not that it'll make a big difference, just for future engagement, that might be helpful. That's what I do sometimes.
Okay.
Great.
Excellent result.
Because of time, so Myeong-Ki, want to close?
Okay.
Yep.
I think the SJ bar and the TW bar show us the really great cases. Also, this case is a real educational and practical and the real live cases. This is 2 cases include the very high the end of the technical procedure, including the importance of the imaging guided left main bifurcation. Okay, I really enjoyed the 2 cases. I learned a lot of the thing from the 2 operators. Thank you.
Thank you, appreciate. Thank you, wonderful.
Thank you.
Thank you, appreciate.
Thank you.
Thank you.